Very good evening, everyone. Myself, Dr. Venkatesh Karthikeyan, Community and Family Medicine Resident from AIIMS Patna. I first of all thank Dr. Jamna Rani ma'am and the management of Bharat Medical College for taking up this important topic and giving me an opportunity to share few key insights with the participants. We are here at Bharat Pathocon to discuss about Anemia Mukt Bharat. We had excellent sessions on RBC histogram, myeloproliferative neoplasms, approach to hemolytic anemia, flow cytometry, and other topics. And the very idea of the team and Dr. Jamna Rani ma'am to add the topic of Anemia Mukt Bharat itself is appreciable. Rather, it is noble, owing to the fact that anemia is of a great public health concern and showing this public health angle in the minds of the participants who are PGs, consultants, and doctors from different parts of the country will help to overcome this problem and will have a greater impact. So, for the next few minutes, I'll orient our participants about the importance of the topic, the timeline, and then the objectives of Anemia Mukt Bharat and the 6x6 strategy, which is 6 beneficiaries, 6 interventions, and 6 institutional mechanisms under Anemia Mukt Bharat. Then, what is new about Anemia Mukt Bharat? What have we done before, and what is newly introduced in Anemia Mukt Bharat? And I'll end with the take home message. So, mine will be a very short presentation where I'll be sharing very few key points, especially about more focus on the 6x6 strategies. Okay. So before going to Anemia Mukt Bharat, first of all, what is anemia? Okay. Anemia is a condition in which the number of red blood cells or their oxygen carrying capacity is insufficient to meet the body's physiological requirements, which vary by age, gender, altitude, smoking habits, and during pregnancy. In simple terms, anemia is the reduction in quality and quantity of RBCs. So, why does one get anemia? Anemia may be due to many reasons like folic acid deficiency, B12 deficiency, vitamin A deficiency. It can be due to chronic inflammation, infectious diseases, malaria, TB, G6PD, lot of things. But what is the most common reason? The most common, single most preventable and important cause of anemia is iron deficiency anemia, as all of you know. Okay. So what is the cutoff for calling someone to be anemic? Okay, so to see that, we'll see what is a normal range of hemoglobin. If the hemoglobin level is more than level 11 in children between 6 to 59 months of years, it is normal. For children between 5 to 11 years, it is more than 11.5. For children between 12 to 14 years, is more than 12. For non-pregnant women, the hemoglobin should be more than 12. In pregnant women, it should be more than 11. And in men, it should be more than 13. Okay. So when do we call it as a severe anemia? When the hemoglobin level is less than 8 grams per deciliter in all the age groups except for children below 5 years and pregnant women, we call it as severe anemia. And in children below 5 years and pregnant women, a cutoff of less than 7 gram per deciliter is called as severe anemia. I'm not going into the differentiation between mild and moderate anemia because the treatment is overall the same. Okay. So if you want to take something away from this slide, if you want to carry something from this slide, we call anything less than 8 grams per deciliter to be severe anemia in all the age groups except for children below 5 years and pregnant women, where a cutoff of less than 7 gram per deciliter is considered as a severe anemia. Okay. So when does a problem like anemia becomes a matter of public health importance? Okay. Whenever the prevalence of anemia is more than 5%, then it becomes a matter of public health importance. If it is between 5 to 19%, it's a mild public health problem. If it is between 20 to 40%, it's a moderate public health problem. And if it is more than 40%, it's a severe public health problem. That is, when the prevalence of anemia is more than 40%, then it is considered as a severe public health problem. Okay, where do we stand? See the figures of India. The prevalence of anemia amongst children between 6 to 59 months is 67%. Okay. Adolescent girls, the prevalence is 59%. Adolescent boys, it is 31%. In women of reproductive age group, it is 57%. In pregnant women, it is 52%. And lactating women is 57%. All this is based on the National Family Health Survey 5, which is the most recent one based on 2019 to 2021 data. Okay. Let me spend few more minutes on stats on the figures. See, in this is a screenshot taken from the live anemia dashboard. Okay, if you go to Google and search Anemia Mukt Bharat, you'll be taken to Anemia Mukt Bharat dashboard, which will show you all the numbers in an updated fashion, in a real time and in a dynamic way. Okay, so here what you can see, this red column indicates, this red bar indicates the prevalence of anemia in 2015 to 2016. Okay, and this orange color indicates the latest data, NFHS 5 based on 2019 to 2021, and this green color indicates the target which was set to be achieved before by the end of 2022. Okay, so what you could see, the prevalence among adolescent boys was 29.1 percentage, and now it is 31.1 percentage. But the original plan which we plan to achieve, the original target which we plan to achieve by this year end is 11.1 percentage. You can see there is a huge gap between the what is the target and what is the current situation. And to add to this, the situation is worsening. The prevalence of anemia is increasing when compared to the previous statistics. This is mainly attributable to COVID, which caused disruption in the healthcare services. Okay, so let's move to the adolescent girls, where again the prevalence is 59 percentage, which is much more higher than what was the situation in 2015, and the gap is increasing furthermore. Similarly, in children between 6 months to 59 months of age, the prevalence is 67 percentage, which is again worsening. And in lactating women, it is almost the same. There is no much improvement or depreciation. In pregnant women, it is 52 percentage, which again increased. And in women of reproductive age group, it is 57 percentage, which is again increased. What you could see when what we discussed that when it is more than 40% prevalence, then we call it as a severe public health problem. What is the status of India? With exception to adolescent boys, all the other age groups have a prevalence of more than 40, like even 50 to 60 in some cases. So this is how important this problem is. Thus, we need to focus more on anemia. Okay. So why do we have such a high burden of anemia? It can be due to a lot of reasons. It can be due to low iron stores. So iron stores may be lower during pregnancy, especially among the anemic mothers. So anemic mothers become anemic children. I mean, anemic mothers give birth to anemic infants. They grow up to become anemic children, and they become anemic adolescents. Again, they when they become mothers, they again remain an anemic mother, and they again give birth to an anemic infant. So this cycle keeps on continuing if we don't intervene appropriately. Okay. So dietary reasons also can be there. Starting with the first reason, it can be due to inappropriate infant and young children feeding practices, especially at the time of introduction of complementary feeding. We'll see the details in the upcoming slides. And then it can be due to excessive consumption of iron inhibitors like tea, coffee, calcium-rich foods, and due to low intake of iron enhancers like vitamin C. It can be due to low bioavailability of dietary iron, and more importantly, as I said, decreased in intake of iron. Okay, it is estimated that around 50% of the population take less than 50% of the required daily allowance. So all these could be the dietary reasons. Anemia can be due to iron loss as well, which may be due to parasitic load like malaria or intestinal worms. So this poor environmental sanitation, unsafe drinking water, and inadequate personal hygiene habits can be contributing reasons to the increased parasitic load. Okay. Again, maternal anemia is very common. It can be due to increased iron requirement during pregnancy. It can be due to postpartum hemorrhage. It can be due to low maternal age at the time of conception or inadequate spacing between two childbirths. Okay. So, and why should we bother? Let anemia be there. I'll feel weakness. Okay. Why it's a big deal? Even though if it is more than 40 percentage, what public health concern it raises? Why are we so much bothered? Because anemia reduces the physical development. It has impact on the pregnancy outcome. It reduces the cognitive development, and more importantly, it has economic impact as well. Okay. So anemia basically reduces the physical development, it reduces the productivity, the work output, and work capacity. Okay, it is estimated that in India, Pakistan, and Bangladesh alone, the physical and cognitive losses due to iron deficiency anemia is costing more than $4.2 billion each and every year. Okay, and it has great impact on pregnancy outcomes. It is a leading cause of maternal mortality, and about 20% of maternal deaths are caused due to anemia worldwide. It also leads to neural tube defects, low birth weight, and stillbirths. And anemic pregnant women are more prone to increased morbidity and mortality, and there is 3 times increase in incidence of premature delivery if a mother is having a hemoglobin of less than 7 gram per deciliter. Also, anemia is of great public health concern because it reduces the cognitive development. It decreases the concentration, it disturbs the perception, and delays the psychomotor development. So it basically impairs the language and motor skills, and it's estimated that it can reduce the IQ like by 5 to 10 points. And coming to the economic impact, the WHO and World Bank ratings has declared that iron deficiency anemia is the third leading cause of DALYs, which is disease-associated life years, disability-adjusted life years, which is basically the years of life lost due to disability and years of life lost due to premature mortality. Okay, so it causes a loss of 1.18 percentage of GDP. Which think about the magnitude of economic impact also, especially in a big country like India. Okay, so because of all these four key reasons, we are more worried about anemia from the public health point of view. Okay, so what have we done till now to address this important issue? In 1970, we have launched National Nutrition Anemia Prophylaxis Program. In 1991, we had launched National Nutrition Anemia Control Program. In 2017, we have introduced 12 by 12 initiative. In 2013, we introduced NIPI, which is National Iron Plus Initiative. And very recently, in 2018, we have introduced Intensified NIPI, which is Anemia Mukt Bharat. Okay. So when was it introduced? It was introduced in 2018, and it complies with targets of Poshan Abhiyan and National Nutrition Strategy set by Niti Aayog, which is basically to reduce the prevalence of anemia by 3% each year. Okay. And this strategy is estimated, this Anemia Mukt Bharat strategy is estimated to benefit more than 45 crore beneficiaries in the Indian subcontinent. And the government of India is also committed to the World Health Assembly target of 50% reduction of anemia among women of reproductive age group by 2025. And this Anemia Mukt Bharat is based on the life cycle approach, which I already said. When if a mother is anemic, is a pregnant mother is anemic, then she will give birth to low birth weight baby, which will grow up to be an anemic child, and it will grow up to be an anemic adolescent, and that child will enter a reproductive age group, will become a woman of reproductive age group with anemia, and she once she conceives, she will be again a anemic pregnant mother giving birth to a low birth weight baby. So this is a vicious cycle, and if we don't break this cycle, this will keep on happening again and again. And as I said, the impact caused by anemia, though it is a very simple and preventable disease, iron deficiency anemia, though it is simple and preventable, since we are not addressing it, if we are not addressing it properly, then it will lead to great losses. Okay. So as I said, what are the objectives? It is to reduce the prevalence of anemia by 3% per year in children, adolescents, and women of reproductive age group. So what are the targets set? The targets were set in such a way that by the end of 2022, the prevalence of anemia in children between 5 to 59 months is 40%. The prevalence of anemia in adolescent boys is 11%. In adolescent girls, it is 36%. In women of reproductive age group, it is 35%. In pregnant women, it is 32%, and in lactating women, it is 40%. So these are the objectives and targets set for Anemia Mukt Bharat. Just remember one thing, it is to reduce the prevalence of anemia by 3% each year. Okay. If we remember this, that is more than enough. So what is this? What are the strategies which is being followed or which is being introduced in Anemia Mukt Bharat? It is very famously known as 6x6x6 strategies, which means there are 6 beneficiaries, 6 interventions, and 6 institutional mechanisms. Okay, so who are the 6 beneficiaries? The first group of beneficiary is children between 6 to 59 months of age. The second group of beneficiary is children between 5 to 9 years of age. The third group of beneficiaries is the adolescent girls and boys. The fourth group is women of reproductive age group. The fifth group is the pregnant women. And the last group is lactating mothers. So these are the 6 beneficiaries who will be targeted in Anemia Mukt Bharat. Okay. So what are the 6 interventions? The first intervention is prophylactic iron and folic acid supplementation. The second intervention is deworming. The third intervention is intensified year-round behavioral change communication campaign. The fourth intervention is testing and treating of anemia. The fifth intervention is mandatory provision of iron and folic acid fortified food. And the last intervention is intensifying the awareness, screening, and treatment of non-nutritional causes of anemia in endemic pockets. So these are the six interventions, and we will see about them in detail. So first, what is our first intervention? It is prophylactic iron and folic acid supplementation. A very, very, very important intervention. Okay. So you can see these are the beneficiaries which is listed out and how we are going to give iron and folic acid. It's being mentioned here. For children between 6 to 59 months of age, what we are going to give? We are going to give 20 milligram of elemental iron and 100 microgram of folic acid. Okay. So less than 5 years, 20 milligram plus 100 microgram of folic acid. For children between 5 to 9 years of age, we are going to give 45 milligram of elemental iron and 400 microgram of folic acid. Instead of 20, it has become 45, and instead of 100 microgram of folic acid, it is 400. Okay. In adolescent girls and boys, what we are going to do, instead of 45 milligram, we are going to give 60 milligram of elemental iron, and instead of 400 microgram of folic acid, we are going to give 500 microgram of folic acid. Okay. The same dose, 60 plus 60 mg plus 500 microgram. The same dose is followed for women of reproductive age group and pregnant women and lactating women as well. Okay. So these are the dosage for iron and folic acid. But what is the frequency? See, if we are taking children less than 5 years, we should be giving this IFA syrup bi-weekly. Okay, twice in a week. In case of children between 5 to 9 years, in case of adolescent girls and boys, and in case of women of reproductive age group, the frequency is weekly. So weekly we will be giving one IFA tablet for all these people. And for pregnant and lactating women, we'll give the dosage on a daily basis. Okay. So it is daily for pregnant and lactating women, bi-weekly for children between 6 to 59 months of age, and for other age group, it is weekly. Okay. More importantly, what is the color? Okay. First, if you are taking this 5 to 9 years of age group, it is pink color sugar coated. If it is for adolescent girls and boys, it is blue color, which is again sugar coated. If it is for women of reproductive age group, it is red color, which is again sugar coated. And the same thing is for pregnant women as well. Okay. So, but when to start for this pregnant woman? So, for iron and folic acid supplementation should be started from the fourth month of pregnancy. That is from the second trimester and continued throughout the pregnancy for a minimum of 180 days during pregnancy, and to be continued for 180 days postpartum as well. This will help to replenish the iron stores. Okay. What are the a few concerns which we should be careful while giving prophylactic IFA supplementation? Okay. First thing, this prophylaxis should be given irrespective of anemia status. Okay. Irrespective of hemoglobin level, this prophylaxis should be started. Okay. And if a woman is planning for pregnancy, then what we should do? She is basically a woman of reproductive age group. She's already taking weekly prophylaxis of iron and folic acid tablets. And if she is planning pregnancy, then what should you advise as a doctor? You should advise them to stop this iron and folic acid supplementation and initiate only folic acid supplementation. Okay. One thing which I want to highlight is that the dosage which a woman of reproductive age group will take is 500 microgram of folic acid, whereas the IFA supplementation for someone who is trying to get pregnant is 400 microgram, not 500 microgram. Okay. And what should you do in case of acute illness if the patient is having, if a woman of reproductive age group who is taking this medicine regularly is suddenly having fever or diarrhea or pneumonia, or she's a known case of thalassemia? In all these cases, you can withhold the prophylaxis of iron and folic acid. Okay. So this is in detail about the first intervention, which is prophylactic iron and folic acid supplementation. Okay. What is our next intervention? Our next intervention is deworming. Okay. So this deworming is given again to all age groups. As we know, the drug we use is albendazole 400 mg. Okay. When we should give it? We should give it twice a year, and it will be much better if we are giving it on fixed days. That is why we are celebrating National Deworming Day on February 10 and August 10 every year. So on these 2 days of the year, we'll be administering the albendazole to all the target people. Okay. One thing to note is that if the age of the child is less than 2 years, then the dose will be 200 mg, not 400 mg. Okay. And in case of pregnant women, albendazole is preferably given during the second trimester. Just like the iron and folic acid supplementation, albendazole also should be given in the second trimester. Okay. So we know that coming to the before going to the next intervention, we know that repeated engagement using consistent key messaging is required for any behavior to change or to initiate new behavior, so that it becomes a practice. Okay. So we have a third intervention, which is intensified year-round behavior change communication campaign. Here, what we are going to do, we are going to create awareness and emphasize on complaints to iron and folic acid supplementation and deworming. And then we will be motivating and we'll be campaigning about the appropriate infant and young child feeding practices, which emphasize on adequate and age appropriate complementary feeding for children above 6 months of age. Okay. What else we will do in this BCC campaign? We will be creating awareness about increased intake of nutritious food like iron rich, protein rich, and vitamin C rich foods through a dietary diversification. Quantity and frequency and food fortification will be highlighted. Okay. And very, very important point which I want everyone to remember is that in this intervention we will be promoting the practice of delayed cord clamping. How much delayed? So we should clamp the cord only after 3 minutes or until the cord stops pulsating. By this way, extra few ml of blood enters the infant, and it is going to increase the iron stores and prevent the development of anemia. Okay. And we should and we also create awareness about early initiation of breastfeeding, which is to initiate breastfeeding within 1 hour of birth. Okay. How do we do this BCC? It can be done through various activities like sensitization meeting for the media, for the school teachers and administration. And then we can sensitize the panchayat leaders, local leaders. We can make use of mass media, social media like WhatsApp and Twitter. Even this conference, even this Bharat Pathocon itself, I consider it as an opportunity to sensitize and to create awareness about this Anemia Mukt Bharat and the importance of anemia. So these kind of opportunities should be utilized in order to spread the word about anemia. Okay, we can give special press advertisements and awareness activities on occasions such as National Nutrition Week, National Deworming Day, that is Feb and August 10, and then Women's Day, World Breastfeeding Week, World Health Day. When we are celebrating these kind of days, and we are doing some kind of activities in our departments, or giving some or spreading the, even if you're as simple as posting status in your WhatsApp that today is National Deworming Day, or today is this week is World Breastfeeding Day. Even these small things which we do has a great potential to increase the awareness among people, so they start taking this iron and folic acid supplementation, which reduces the prevalence of anemia. Okay. So these are some of the materials which can be downloaded from the Anemia Mukt Bharat website for free of cost. Okay. So if you are running a clinic, or if you want to if you want to sensitize the general public or conduct some kind of awareness campaigns, you can make use of these materials which are available for free in the Anemia Mukt Bharat website. Okay. So what is our fourth intervention? It is testing and treating of anemia. Okay. This, especially in Anemia Mukt Bharat, we are focusing more on the usage of digital hemoglobinometers for hemoglobin level estimation. Okay. And that too, we give more importance to adolescent boys and girls studying in the government and government aided schools, and also the pregnant women registered for the antenatal checkups. So these are the two broad focus groups in which we are planning to use more and more digital hemoglobinometers for early detection of anemia. Okay. So coming to the treatment of anemia, we have four target groups. Okay. First is target group A. We will screen the children between 6 months to 59 months of age, either at the sub center or during the village health and nutrition day, or in the school or in the Anganwadi center, wherever it is possible. We'll screen. And who will screen actually? We, in the sense, it will be the ANMs who will be screening. Okay. If it is a healthcare setup, then the medical officer will screen. So all the treatment I'm going to discuss in this slide is mainly for mild and moderate anemia. Okay. If it is a case of severe anemia, then we'll directly refer to the first referral unit or to the district hospital, or to some medical colleges. Okay. So what is the dosage in children between 6 to 59 years of age? The dosage is 3 milligram per kg per day for a period of 2 months. Okay. So how we will give in this age group of less than 5 years? We'll be giving a syrup, iron folic acid syrup in the form of syrup. Okay. We'll give 1 ml of IFA syrup once daily if the age is less than 1 year. We'll give 1.5 ml OD for 1 to 3 years of age, and we'll give 2 ml OD for 3 to 5 years of age. Okay. And we will teach the Ashas will teach the mother how to give this syrup. And every 2 weeks, she'll go and visit the baby, and she will find out whether proper practice of giving iron and folic acid syrup is followed or not. Okay. And what we will do at the end of 2 months, we will estimate the hemoglobin again. And if the baby is responding, then we will discontinue the treatment. Okay. But very, very important thing is that it is not that now hemoglobin level is good, we are discontinuing the treatment. Our role does not end with that, but we should motivate the parents to continue the prophylactic dose of iron and folic acid supplementation. This is very, very, very important. Okay. If the anemia has recovered, the hemoglobin level has risen, it does not mean that you should abruptly cut the supplementation of iron and folic acid. What you're going to do, you're going to stop the treatment dose and start the prophylactic dose. Okay. And at the end of 2 months, if it is not improving, if it is not recovering, then what we'll do, we'll refer to the district hospital or the referral units. Okay. So this is about the treatment in target group A, which is children between 6 to 59 months of age. Okay. What is the target group B? Target group B is children between 5 to 9 years. Here, how we are going to reach them? Okay, basically, the RBSK teams, Rashtriya Bal Swasthya Karyakram teams, will reach them by going to the schools or homes, and they will refer them to the PHCs or sub-centers for hemoglobin estimation. Okay. How frequent this activity is done? This activity is done once in a year. And while referring to PHC, if we are finding that the hemoglobin is less than 11.5, then we start the treatment. What is the dosage? Same dosage, 3 mg per kg per day. What is the duration? Same duration, 2 months. Okay. Similar to less than 5 years of age group, once the hemoglobin recovers at the end of 2 months, we will stop the treatment, but we'll continue with the prophylactic dose of iron and folic acid supplementation. Okay. And at the end of 2 months, if there is no recovery and the hemoglobin is still less than 8 gram per deciliter, we will refer the patient to district hospital. Okay. What is our next target group? Our next target group is target group C. Here, it comprises of adolescents between 10 to 19 years. Okay. Here, the RBSK team will go to the school once a year and screen the adolescent children between 10 to 19 years of age. If they are found to be anemic, then they will give 2 iron and folic acid tablets per day, once daily for 3 months. Okay. It is once daily. Okay. We are giving 2 tablets, but at the same time, we will give like if we are giving in the morning itself, we will give both the tablets. Each tablet contains 60 milligram of elemental iron and 500 microgram of folic acid, as discussed earlier. Okay. So this IFA tablet should be given after the meals. Now, when we will check the hemoglobin again, we'll check the hemoglobin again after 3 months, and we will discontinue if there is improvement. But discontinuation is only for the treatment dose, not for the prophylaxis, similar to the other earlier groups, and refer to the higher hospitals if hemoglobin is not improving or the initial hemoglobin itself is less than 8 gram per deciliter. Okay. Coming to the last group, that is target group D, which comprises of pregnant women, we will be screening all the antenatal cases at any point of contact and every point of contact. Okay. Please note this word importantly. Whenever a pregnant woman is coming to you, antenatal woman is coming to you, at the first time, you should at any point, even if she is coming for the first time, at the beginning of third trimester also, at the time also you should check the hemoglobin. And at every point of contact, every time when she comes for a checkup, each time you should check for the hemoglobin level. Okay. If there is mild and moderate anemia, then 2 tablets of IFA, iron folic acid, is given daily. Okay, we can consider starting parental iron of anemia, parental iron, if anemia is detected in late phase of pregnancy, because during the later phases, third trimester or end of second trimester, if we are starting oral iron and folic acid supplementation, it might take time to increase the hemoglobin level. So in such cases, we might consider starting the parenteral therapy directly. Okay. And similarly, we can follow for 2 months and discontinue the therapeutic dose if there is improvement. Okay. And if there is no improvement, or if hemoglobin is less than 7 gram per deciliter in the first encounter itself, then we directly refer to district hospital. Okay. So, but what we have discussed about four different treatment groups. What are the dosage, frequencies, everything. Okay. So all this is for iron deficiency anemia only, and this treatment protocol should not be adopted if we are suspecting someone to be a case of thalassemia or sickle cell anemia. Okay. Few words about the parental iron treatment. We are giving it parental iron treatment when the anemia is severe, that is, hemoglobin is less than 8 gram per deciliter in case of all age groups and less than 7 gram per deciliter in case of pregnant women and children between below 5 years of age group. We will give parental iron in case of moderate anemia, even if it's the case of moderate anemia, if it is the second or third trimester of pregnancy. And then we'll give postpartumly, we will be giving parental iron if oral iron is not tolerable or not suitable or not effective. Okay. So if the patient is having contraindications to oral iron or compliance issues or tolerance issues, he might be he or she might be put for parental iron treatment directly. Okay. And then if a patient is having some comorbidities like the intestinal mucosal disorders, which may impact the iron absorption, then instead of oral IFA, we can go for parenteral iron treatment. Okay. When a patient is also having chronic renal impairment, receiving erythropoiesis stimulating agent, we can consider parenteral iron treatment. And if there is ongoing iron loss, which exceeds the absorbing capacity, then again we can opt for parenteral iron treatment. Okay. So what are the options available? We have dextran-free iron supplement like iron sucrose and ferric carboxy maltose. These two can be used for parenteral iron treatment. Okay. What are the advantages? It helps to overcome the issues which would otherwise be present in case of oral IFA, such as adherence issues, behavior problems, behavior changes, poor absorption, and more importantly, it restores this parenteral iron treatment restores the body iron stores very rapidly when compared to oral treatment. Hence, it might be preferred in necessary situations, just like I mentioned in the later stages of pregnancy. Okay. So this is our intervention about testing and treatment of anemia. What is the next intervention? Our fifth intervention is fortified food. Okay, mandatory provision of iron and folic acid fortified food in government funded health programs. Okay, we can use iron fortified whole wheat flour or rice. And just like we have iodine fortified salt, we have iron fortified salt also. Okay, so these kind of fortification in salt, wheat, and rice should be done, and such kind of fortified items only should be utilized in government funded health programs. Okay, so this is the fifth intervention which is provided by Anemia Mukt Bharat strategy. What is the last intervention of Anemia Mukt Bharat? Our last intervention is intensifying the awareness, screening, and treatment of non-nutritional causes of anemia in endemic pockets with special focus on malaria, hemoglobinopathy, and fluorosis. As I said, iron deficiency anemia is the most common and most preventable cause of anemia. Okay, but it does not mean that all cases are iron deficiency anemia. We should always keep at the back of the mind that there could be other non-nutrition causes also, especially in endemic areas. Like if there in some areas of Tamil Nadu, there is high prevalence of fluorosis. In some regions, in some urban slums, there will be high prevalence of malaria. In some regions, there may be increased prevalence of hemoglobinopathies. So all these endemicity should be kept in mind if a patient is presenting to you with anemia, especially if they're not responding to your iron and folic acid supplementation. Okay. So in malaria, testing for anemia in those who are tested for malaria should be done. Okay. And similarly, you should test for malaria in those who are anemic and have fever. Okay. It's kind of co-testing. If an anemia patient is coming with fever, you should check for malaria also. If a malaria patient is coming, you should check for anemia also. So by this way, you can easily pick up more number of anemia cases and malaria cases as well. Okay. Similarly, Anemia Mukt Bharat is also playing a key role for utilization of long-lasting insecticidal nets by all target groups with special preference to the pregnant women and under 5 children, which is mainly by promoting via the behavior change communication campaign and by distributing IC materials. So basically, non-nutritional causes of anemia can be many, but the most common are malaria. Most common is malaria, hemoglobinopathy, and fluorosis. In malaria, we'll be promoting the usage of long-lasting insecticidal nets, and we will test for malaria and anemia. Co-testing will be done. Okay. And coming to hemoglobinopathies, Anemia Mukt Bharat focuses on comprehensive prevention, screening, and management of hemoglobinopathies. And we are also more focused on providing counseling and screening services to premarital group and preconception group as well. Okay. So the last non-nutritional cause we are going to discuss is about fluorosis. Here, the high fluoride concentration in food and water basically leads to the destruction of gastrointestinal mucosa. Okay. So when the fluoride level is high, it is going to destroy the gastrointestinal mucosa. Thus, the reduction in iron and folic acid is going to happen. Okay. That is why this national program for prevention and control of fluorosis recognizes the linkage between fluoride, anemia, and malnutrition, and has given us three key interventions. One is identification of fluoride affected inhabitants. Second is anemia control for fluorosis, behavior change communication, and combined approach of safe drinking water and nutrition improvement. And the third intervention is capacity building. Okay. So we have discussed all the 6 interventions under Anemia Mukt Bharat. What next? It is the institutional mechanisms. There are 6 institutional mechanisms. Okay. Namely, intra-ministerial coordination, establishment of second one is establishment of Anemia Mukt Bharat unit. Third one is planning to establish National Center of Excellence and Advanced Research in Anemia Control, which will be in AIIMS Delhi. And then fourth intervention is convergence with other ministries. The first one was intra-ministerial coordination. Fourth one is inter-ministerial coordination. And fifth institutional mechanism is going to be strengthening of supply chain and logistic. And the last intervention is going to be the Anemia Mukt Bharat dashboard, which is a wonderful dashboard which gives us real-time data about the status of anemia, and it shares a lot of key performance indicators with us, which is made available to the public. So these are the 6 institutional mechanisms. So let's see one or two points about each of these. Okay. So what is the first institutional mechanism? It was intra-ministerial coordination. Okay. So at the national level, the existing Rashtriya Kishore Swasthya Karyakram, National Steering Committee, will be expanded to include the National Anemia Mukt Bharat Steering Committee. Okay. This steering committee will have biannual convergent meetings in coordination with the respective divisions of Ministry of Health and Family Welfare and other related ministries like the Tribal Welfare, Ministry of Women and Child Development, Ministry of Rural Development, Panchayati Raj, and other experts from different ministries as approved by the chair then and there. Okay. So this intra-ministerial coordination is the first institutional mechanism put forward in the Anemia Mukt Bharat. Okay. The second institutional mechanism is establishment of Anemia Mukt Bharat unit. We have a national Anemia Mukt Bharat unit which supports and monitors the states for strategy implementation. We have a state Anemia Mukt Bharat unit which ensures accountability and effective implementation. And we have units in each district which is responsible for carrying out the day-to-day implementation of Anemia Mukt Bharat activities. Okay. So we have seen 2 institutional mechanisms. What is the third institutional mechanism? That is establishment of National Center for Excellence and Advanced Research on Anemia Control, which is by the Department of Community Medicine of AIIMS Delhi. Okay, it will be established at AIIMS Delhi. It will serve as the apex. Actually, I'm telling it in future tense because it is not yet fully functional. Okay, this is a proposal and this is ongoing. Okay, so this National Center for Excellence will be an apex national lab for anemia screening and diagnosis, and it will provide technical inputs regarding policy making, program guidelines, and implementation, and it will facilitate periodic program reviews and capacity building of anemia control program. Okay, it will also support the sample chain monitoring. So this is the third institutional mechanism under Anemia Mukt Bharat. What is the fourth intervention mechanism? It is convergence with other ministries. Okay. So basically under Anemia Mukt Bharat, we are trying to coordinate between different divisions of the Ministry of Health and Family Welfare, and also we are trying to coordinate with the other ministries apart from Ministry of Health and Family Welfare also, because health is a very complex subject and it needs contribution from different domains, different ministries. So realizing that we have applied this principle in anemia control also, and this Anemia Mukt Bharat emphasizes on inter-ministerial and intra-ministerial coordination as well. Okay. Also, what is the fifth institutional mechanism? It is strengthening of supply chain and logistics. Okay. So we have introduced auto intents at district levels, centralized procurement at state level, and IFA and albendazole is now considered as a part of essential drug, and it is being included in the essential drug list. Also, the state will strengthen the convergence with the central drug warehouses, and periodic verification and audit of the supply chains at all levels will happen. Okay. So what is the last intervention? That is the establishment of Anemia Mukt Bharat dashboard and digital portal. Okay, if you just type Anemia Mukt Bharat in Google, you'll get this wonderful website with a wonderful dashboard which has all the materials such as communication resource material, survey data, targets, state and district wise denominators, and state and district wise quarterly progress reports as well. I think up to quarter one of 2022, progress reports are available. Okay. All these resources can be efficiently utilized for planning, implementation, and monitoring of strategy. Okay, it is available freely. You can download free of cost, and there is also a mobile application for it as well. Okay, so these are the 6 institutional mechanisms of Anemia Mukt Bharat. So, what is new in this Anemia Mukt Bharat? Just few key points. First, Anemia Mukt Bharat is more focused on coordinated efforts within the ministry and with other ministries. Okay. So, and also it is target based. Okay. It is not that we are making policy and you give the iron tablets. It's not like that. We have set targets, and we are there will be a strict monitoring whether this target is achieved or not. We'll have key performance indicators, reviews, and we'll be giving awards to best performance also. Okay, here the dosage is changed from 60 milligram of iron instead of 100 milligram of iron, which is a prophylactic dose, and these tablets are sugar coated as well. Okay, to increase the palatability. Okay, and then what's new in Anemia Mukt Bharat? We have communication materials for extensive awareness, intensive 360-degree communication campaigns, and we are more focused on creating a Jan Andolan, which is nothing but encouraging the people's participation in this program. Okay, and we are using digital methods of hemoglobin estimation, and especially at the point of care. So we are trying to diagnose and treat at the point of care, and we have brought in new treatment strategies also, which was discussed extensively in this presentation. And we are linking it with malaria. As I said, a malaria patient will be tested for anemia, and an anemic fever patient will be tested for malaria. So this linkage is there. That is new in this program. And we have mandated the use of fortified food, like double fortified salt or fortified rice and wheat flour with iron. So all this we are introduced. Okay. So these are the new things which are in few of the new things which have been initiated under Anemia Mukt Bharat. Okay. Especially, I'll end my presentation in next 2-3 minutes. I'll just summarize what we have seen now. We have seen what is anemia, what is the diagnosis criteria for anemia, why it is a public health problem, what are the interventions, what have we done till now, what is this Anemia Mukt Bharat, what is the 6x6 strategy, who are the 6 beneficiaries? That is children between 6 to 59 months of age, and children between 5 to 9 years of age, adolescent boys and girls, women of reproductive age group, pregnant women, lactating women. So these are the 6 beneficiaries we saw. We saw the 6 intervention, which is providing prophylactic iron and folic acid supplementation, providing albendazole tablets, providing year-round behavior change communication campaigns, and then testing of anemia using digital methods and point-of-care treatment, mandatory provision of fortified food, iron and folic acid fortified food in public health programs, and then addressing non-nutritious cause of anemia like malaria, fluorosis, and other hemoglobinopathies. So these are the 6 interventions we discussed. What are the 6 institutional mechanisms? Establishment of Anemia Mukt Bharat unit at the national level and state levels, intraministerial coordination, strengthening of supply chain and logistics, convergence with other ministries, establishment of National Center of Excellence and advanced research on anemia control, and establishment of Anemia Mukt Bharat dashboard. Okay. So, what I want you to take home is that we are clinicians, postgraduates, practicing doctors. Okay. If we are keeping at the back of the mind that these are the 6 beneficiaries group and these are the interventions, if we are keeping at back of our mind always, it will help us to pick up cases of anemia and treat it at early stages, thus breaking the vicious cycle of anemia, which I explained in women, pregnant women, anemic pregnant women giving rise to an anemic low birth weight baby, that baby becoming anemic children. So this vicious cycle can be broken if we are intervening appropriately at the right time, and this will lead to increase in productivity of the individual, productivity of the society, and productivity of a country as a whole. Okay, so that's it in my presentation. If you have any queries, you may please ask.